welcome everyone, and thanks for attending today's noon conference. So I'm looking forward to talking to you about in-flight medical emergencies. And if you're wondering why I'm specifically talking about this topic, is because I've been involved in a fair number of them. And I decided to learn more about these emergencies as well as aviation physiology, including the practical, pragmatic aspects of delivering care on an aircraft, but also the physics and the physiology, as well as the legal aspects of what goes on in these situations. So let me start with a case scenario. This happened 5 years ago now, and I was in Beirut taking a flight back to Detroit, and I had a connection in Europe. So on the initial flight from Beirut to my connection in Europe, it was a very early flight. It was a 4 a.m. flight, and I was sleeping, but then we were all startled by the overhead speaker asking for a medical provider on board. So I wake up and find the nearest flight attendant and was directed to go to the back of the aircraft. So I get there and I find a pregnant woman lying unconscious on the floor. So she was, by my initial estimate, in her eighth months of pregnancy, and she was totally unconscious on the floor. And obviously, as I'm starting to perform my evaluation, one of the flight attendants comes behind me and asks me, the captain is asking whether you recommend diverting the aircraft. And I'll get into more details about such decisions, but this is a case scenario I want to start with, and I'll come back to this case at the very end of the lecture. So for today's lecture, I am addressing 6 specific questions listed here in my outline slides, specifically how frequent are IFMEs, and I'm using the IFME abbreviation for in-flight medical emergencies. What travel-specific factors contribute to IFMEs? What are the most common causes of IFMEs? What medical resources are available on board? What are the outcomes of such events? And what about legal protection for Good Samaritans responding to such events? So we'll go through these questions sequentially, and let's start with the first one: how frequent are IFMEs? So the true incidence is unknown because, one, there is no consistent definition of what an IFME is. I mean, some airlines will record an IFME as a minor fall, whereas some others may consider an IFME an event that specifically requires consultation with ground-based medical support staff. And also, there is no mandatory or uniform reporting system across the world. And because of that, their true incidence is unknown. However, what we do know is that they have been increasing in recent years due to several factors. One, there have been more air travelers. In 2018, it was estimated that there were 4.3 billion travelers. 2, older air travelers. I mean, the population is aging as a whole, and we are seeing older air travelers as well. Improved mobility of people with chronic diseases. And this relates to, improved wheelchair equipment, improved supplemental oxygen, and even people are now able to travel with trachs. So the improved mobility, especially over the past 20 years, is a contributor. And finally, the growth of medical tourism, especially in certain parts of the world where people with known coexisting medical conditions, and sometimes severe conditions, are traveling to get care somewhere else. So these factors have led to an increase in the incidence of IFMEs. Now, like I said, the true incidence is unknown, but it's not like we don't know anything at all. And I want to refer to this study published in the New England Journal of Medicine in 2013. And I'll be referring to this study throughout my presentation today. But it's basically a study looking at the outcomes of these events, and it was led by a group of physicians at the University of Pittsburgh. And just a brief overview of this study: it looked at 5 domestic and international airlines. These were major airlines, as the 5 of them accounted for 10% of the global passenger volume. They looked at events through almost 3 years, from January 2008 to October 2010. And this period spanned over 7 million flights and close to 750 million passengers. And as far as I know, this is the largest study that looked at outcomes of IFMEs. And this is why I'm highlighting it and will be referring to it throughout this talk. Now, in terms of incidence of IFMEs, they found 16 IFMEs per 1 million passengers and 1 IFME per 604 flights. Now, these numbers are considered to be underestimates. Some smaller studies have found the incidence of IFMEs to be as high as 130 per million passengers. But basically, this gives us a rough estimate, of how frequent these events occur. Now, some other authors did an extrapolation of how many IFMEs are encountered every day worldwide based on air traffic volume. And depending on how busy a given day is, it can be anywhere between 250 and 1,500 IFMEs on a given day. So the takeaway here is that they are not extremely frequent. However, because of the volume of passengers and the volume of air traffic, the sheer numbers of IFMEs is not that uncommon. So I'll move on to my second question. What travel-specific factors contribute to IFMEs? And here I really want to think about these factors as factors related to the stresses of long-distance travel, so factors related to travel itself, and a second set of factors which is related to the environment on the aircraft, the cabin environment, basically. So let's start with stresses from long-distance travel. So as you can see listed on the slides, most passengers can encounter such stresses, starting with sleep deprivation, right, which is important, especially in vulnerable or older people where sleep deprivation can affect, the circadian system and just can make comorbidities worse. Second factor is disruption of medication schedule, and this can be particularly important with certain kinds of medications. For example, the medications for diabetes, where especially when it involves insulin, you want to take them on a regular schedule to avoid complications. Another set of medications could be antihypertensives, especially for people who have labile blood pressure. A third set of medications could be anti-epileptic medications for people with a history of seizures or epilepsy. Third factor is anxiety, and anxiety comes with a increase in heart rate, increase in respiratory rate, which would be tolerated fine usually by the average passenger, but could cause important physiologic disruptions for more compromised individuals. And finally, lifting heavy luggage. I mean, many of these people can find themselves in a situation where they have to lift heavy luggage, whether at the airport or inside the aircraft, and this can put significant stresses on their body, especially if they are not very active or they're not used to lifting heavy stuff in their daily lives. So these are predisposing factors that are specifically related to stresses from travel. Now let's move on to the factors that are stemming from the cabin environment. And I've listed them there on the slide, including lower oxygen and lower air pressure. And I'm going to discuss these two factors in much more details in my next slides. But I want to highlight a few more factors, starting with lower humidity. So the optimal humidity is usually 40 to 50%, the level of humidity in the air, 40 to 70%. Now, in an aircraft, you would usually encounter a humidity level of 10 to 20%, which is much, much lower than an optimal level. And you can feel it. You can feel it when you are sitting in an aircraft in terms of drier skin and drier nasal and oral mucosa. Now, for the average passenger, it will not be a big deal, cause mild discomfort. But for certain conditions like bronchiectasis or the chronic bronchitis phenotype of COPD or people with trachs, this significantly lower humidity can become problematic, starting with much thicker secretions. Second factor I want to talk about is air turbulence. It can be problematic for two reasons. One, it can result in motion sickness and eventually lead to gastrointestinal symptoms, but also it can lead to heavy objects falling, which can cause significant trauma, especially if it is head trauma. Third factor I want to highlight is prolonged immobility, which we're obviously very familiar with, in terms of predisposing to a higher incidence of venous thromboembolism, especially in people who have clotting disorders, obese people, and women who are taking oral contraceptives. So keep these factors in mind. And now I want to talk more about lower oxygen and lower air pressure. So let's start with lower oxygen. So in this table, I have shown how barometric pressure, tracheal tension of oxygen, and the PO2 vary at two different altitudes, 0 feet, which is sea level, and 8,000 feet. Now, to take a step back, like large aircrafts that travel long distances, usually more than 750 miles, cruise at an altitude of 30,000 to 40,000 feet. Now, the FAA, the Federal Aviation Administration, mandates that the aircraft be pressurized to an altitude of 8,000 feet or less, but the maximum it can be pressurized to is 8,000 feet of altitude. Now, and this is why I have 8,000 feet listed there on the table. So at this altitude, your barometric pressure would decrease from 760 to 565 compared to sea level. Your tracheal PO2 would be lower from 150 to 110, and your PO2 would be lower from 100 to 60. And there was one study where they asked passengers to measure their oximetry both at the airport before boarding the aircraft and then during flight. And the average oximetry at the airport was 99%, and the average oximetry during flight was 94%, which roughly fits with what I'm showing for PO2 on the table there. Now, going back to the oxyhemoglobin dissociation curve, which I'm showing here. So let's say, you usually live here and you end up dropping to here, no big deal, right? I mean, you're still maintaining adequate PO2 and oxygen saturation. But let's say, you are living here, due to a chronic lung or heart disease, and then you end up dropping closer to here on this steeper part of the oxyhemoglobin dissociation curve. This is when trouble occurs, especially if you have an unknown pre-existing condition, have not been following up on your care with your providers, or did not take the adequate precautions in terms of setting up supplemental oxygen before boarding the flight. And also another thing I want to mention is that our bodies are primed to counter this decrease in oxygen and these additional stress by some physiologic adaptations, namely an increase in cardiac output, usually driven by an increase in heart rate, but also an increase in minute ventilation, driven by an increase of both the respiratory rate and the tidal volume. Now, a couple of points I want to make because people ask these questions. One question is, why wouldn't aircrafts pressurize the cabin the same as sea level? Meaning, why don't you pressurize it with basically barometric pressure of 760 millimeters of mercury, same as sea level? Well, the answer is, remember, these aircraft are flying at very high altitude, 30 to 40,000 feet, where the surrounding pressure at that altitude is very low. So if your pressure inside the aircraft is very high, it can create such a high pressure gradient that it would damage the fuselage of the aircraft, which could be dangerous just because of this high pressure gradient. So this is really not safe and not possible. So this is why you cannot do that, and this is why you have to pressurize the cabin for a higher altitude, usually between 4,000 and 8,000 feet, but no more than 8,000 feet as mandated by the FAA. And then second question people sometimes ask is, why don't these aircrafts just fly at a lower altitude? And if you're flying at a lower altitude, let's say at I don't know, 10 or 20,000 feet instead of 30 to 40,000 feet, you would be able to maintain a higher barometric pressure inside the aircraft. Well, the reason is because it would be very costly in terms of fuel. It's just economically not possible. And the reason for that is that encountering higher drag at lower altitudes. Because at lower altitudes, the air is much more dense than at higher altitudes. And because the air is more dense at lower altitudes, the resistance the aircraft would encounter while flying would be much higher. And to be able to overcome this resistance, which is traditionally called drag in aviation terms, you will need a higher thrust from the engine, in addition to all the lift that is coming from the Bernoulli's force acting on the wings of the aircraft. So, but because you will need the higher thrust from the engine, you'll need to burn more fuel. And this is just not economically possible, especially when you keep in mind the thousands of aircraft that travel worldwide every day. So this is as far as lower oxygen is concerned. Now let's talk a bit about reduced air pressure or lower air pressure. And this really comes back to the physics principle of Boyle's law, which basically states that the pressure times volume product is a constant. And I just showed you that the pressure you will encounter on an aircraft is lower than at sea level. Okay, so roughly 565 millimeters of mercury compared to 760 millimeters of mercury on sea level. So this is roughly a 30% decrease in pressure. And if we follow the principle of Boyle's law, this would translate in a 30% increase in volume. Now, in certain situations, this 30% increase in volume can be quite problematic. And I will give a few examples here. Air expanding in your middle ear, which can cause barotitis media or barosinusitis. And I'm going to talk more about this later in the lecture. Pneumothorax, right? I mean, if someone has a COPD with very severe emphysema or some very large bullae, these bullae can expand and eventually result in a pneumothorax, which could be a tension pneumothorax. Same thing for after certain thoracic procedure. And the example I like to use here is our bronchoscopic long volume reduction procedure, where we place these one-way endobronchial valves. And this is why we specifically counsel patients not to travel for 30 days after the procedure. And because they would be at much higher risk of pneumothorax while in the air. And this is particularly important around this time of the year when many of our patients go spend the winter in Florida. So I'm currently evaluating many patients for the valves, and some of them are planning to go to Florida. So we're coming with plans to either defer valve placement till the spring when they come back, or delay travel plans to Florida for at least 30 days after valve placement, or travel to Florida by car and not by air. Another complications of this reduced air pressure and expansion of volume can be bowel perforation or wound dehiscence after abdominal surgery, especially as you know that a lot of the gut is already filled with air. Another complication is gas expansion in the ocular globe after ophthalmologic surgery. So many of the surgeries that occur on the retina, so retinal surgeries, involve injection of gas inside the ocular globe. So travel is not recommended after such procedures, because otherwise it can lead to gas expansion and damage to the globe. And finally, dysfunction of medical devices, including urinary catheters, feeding tubes, and tracheostomy tubes. So these tubes have a pneumatic component to them, right, because of the balloons they contain. And obviously, if this balloon inflates too much, it can basically burst, which will lead to malfunction of these devices. One possible solution to this is to inject water instead of air, let's say in a tracheostomy tube, but in a tracheostomy tube balloon, but or cuff. But obviously, this depends on the specific type of device, whether you can do this or not. And another thing I want to mention here is insulin pumps. So insulin pumps can malfunction because of this phenomenon. The reason being, is if there happens to be air bubbles inside the insulin solution or inside the pump, these air bubbles can expand and eventually lead to malfunction of the insulin pump and an incorrect delivery of insulin, which obviously can be quite problematic and could lead to hyper or hypoglycemia depending on the situation. So keep that in mind if you're encountering such a situation. Insulin pumps can malfunction sometimes. So now that I've covered some of the travel-related and cabin environment-related factors that can contribute to IFMEs, let's go through what are the most common causes of IFMEs. And I will refer to this very nice review published in JAMA in 2018. And in this review, they basically looked at all the studies that examined the specific questions, including the causes and outcomes of IFMEs. And in their table 1, they list these studies. The very first studies there, Peterson et al. Is the study I've been referring to. But then there are other studies they have listed here. And when they combine these studies, they would be looking at close to 50,000 IFMEs. And if you look at the most common causes, syncope or near syncope is the most common, accounting for almost a third of IFMEs. The next one is gastrointestinal symptoms at 15%, respiratory symptoms at 10%, cardiovascular symptoms at 7%, but this does not include cardiac arrest, neurological symptoms at 5.5%, and then you see the rest all the way down to cardiac arrest, which came at 0.2%. Now, I want to go back to the study by Peterson, where they examined causes of IFMEs, and they were a bit more granular in what they described. So in that specific study, again, syncope, pre-syncope came at 37%. And this is a common cause of IFMEs for many reasons. Again, prolonged immobilization, anxiety, alcohol ingestion can all contribute to syncopal or pre-syncopal events. Respiratory symptoms came at 12%, and this is usually in the setting of an asthma or COPD exacerbation. Nausea and vomiting at 9.5%, and this can be related either due to motion sickness from turbulence, or like I said before, air can expand in different compartments of the body, and this can also include, the stomach and the gut, and could result in GI symptoms such as nausea. Cardiac symptoms came at 7.7%, and the most common cardiac symptom by far was chest pain. And cardiac symptoms were the leading cause of death from IFMEs, but also of aircraft diversion. And seizures came at 5.8%. And then they listed a number of other causes that were less frequent, but nonetheless still important. I will point to stroke at possible stroke at 2%, diabetic complication at 1.6%, which, like I said, can come from a disrupted medication schedule or from a dysfunctional insulin pump. Obstetrical or gynecologic symptoms at 0.5%, and cardiac arrest at 0.3%. So I hope this gives you an overview of the distribution of causes leading to these in-flight medical emergencies. Now, one thing I want to point out and that I found very interesting is a phenomenon of acute Bell's palsy, which can mimic a stroke. And there have been a number of case reports on this, and I'm including here one of them published in the Annals of Internal Medicine a couple of years ago. And basically, I will read what this physician encountered and described. And he said, shortly after reaching cruising altitude on a recent airline flight, I responded to a flight attendant's request for a doctor on board. She reported that a passenger was probably having a stroke. When I met the passenger, I found him to be young and fit-looking with a complete right-sided facial droop. In addition to the facial droop, he had lost his forehead wrinkles and could not close his right eye. He reported that several minutes earlier, he had an abrupt onset right-sided headache with ear pain and fullness that progressed to slurred speech and drooling. He had no medical history and was taking no medications, but he had recovered from a head cold the day before the flight. He reported no changes in vision, swallowing, or taste. The functions of his other cranial nerves were intact, as were his mental status, strength, and coordination. So this patient was not experiencing a stroke. He was experiencing an acute Bell palsy. Why did this happen? So going back to basic ear anatomy, which I'm showing here. So you have the cochlea, part of the inner ear. You have the middle ear right here, and you have the outer ear with the tympanic membrane separating the middle ear and the outer ear. So what happened in that situation is because of Boyle's law I described before, because of the decreased pressure in the aircraft, the volume in the middle ear component increased quite a bit. Now, usually, if you have a functional eustachian tube, you can equilibrate that volume between your nasopharynx and your middle ear. But I think it was key that this patient had a cold, was recovering from a cold the day before, and therefore was probably not having a fully functional eustachian tube, which prevented full equilibration between the nasopharynx and the middle ear. And therefore, gas expanded in the middle ear compartment. Now, one of two things can happen. I mean, sometimes this can lead to a rupture of the tympanic membrane, and which would be barotitis media, basically. But sometimes what would happen is air could be transmitted through these defects in the bony canal leading to the facial nerve. So these defects, and you see a depiction here, happen in about 60% of people. Now, if this extra pressure transmits through these bony defects, what it does, it transmits to the blood vessels feeding the facial nerves, and because it affects these blood vessels, you know, the facial nerve would be affected by ischemia, which we would call neuropraxia, and this is the facial nerve, as you remember, the seventh peripheral nerve, which would result in the symptoms and the signs described here, including acute Bell's palsy. So you would suspect this, you know, if this happens right when you reach cruising altitude, so during ascent or right when you reach cruising altitude, and usually presents with an abrupt onset of unilateral ear pain, unilateral headache, and the neurological signs associated with a seventh nerve palsy, and typically resolves on its own after maneuvers such as yawning, for example, or swallowing. And what these maneuvers would do is equilibrate the pressure between your middle ear and your nasopharynx to relieve this pressure off the blood vessels feeding the facial nerve, and symptoms eventually resolve. And this is what happened to this passenger. I'll also note that this is also a common scenario in scuba diving when divers ascend from scuba diving. So keep that in mind. I mean, obviously, it can be a scary situation because it could still be an actual stroke depending on the actual context, but something to keep in mind. Moving on to my next question. So what medical resources are available on board? So I just described what are the most common causes of these events, but what can you do about them? And before I delve into that, I just want to review who actually responds, you know, to these events. And in one study, you know, about half of the events had a physician involved in them, and 1 in 5 events had a nurse involved in them. And obviously, sometimes there would be more than one provider responding at once. But another thing I would highlight is in some of the studies, up to 70% of events were handled by cabin crew alone. And the FAA mandates that cabin crew get trained in CPR and AED equipment every 2 years. Every 24 months, it's a mandatory requirement that they be trained in such devices, specifically to respond to such events, especially if there doesn't happen to be passengers who are healthcare professionals, such as physicians, nurses, or EMS providers. Now, a very important resource is the availability of ground-based medical support. So this is usually provided by ED physicians who are trained in telemedicine, aviation physiology, and management of such events. And usually these are third-based parties. So 30 years ago, some aircraft had their own medical teams, but this model has fallen out of favor. Right now, you would have these third-based parties who provide such services to a number of different airlines. And how would this ground-based medical support occur? Really in one of two ways, depending on aircraft capability. I mean, if the aircraft is newer, they may be able to connect with you right on the spot, meaning you may be able to connect with them through audio or video while providing care to that passenger, like on the spot. But some aircrafts do not have that capability, and you would have to go through the cockpit. Now, granted, after 9/11, you cannot go to the cockpit. It will be someone who will relay your messages to, the pilot, like a flight attendant would relay your messages to the pilot, who would relay them to the ground-based medical support, will eventually get back to the pilot, and the pilot will get back to you through one of the flight attendants. Now, these ground-based medical support services are being used more and more frequently. And looking at some data, this is rather older data, but looking at Air France, about 4% of events required help from a ground-based medical support team. And this was between 1998 and 1999. But about 5 years later, looking at data from Lufthansa, about 10% of events required help from ground-based medical support. And another thing I will mention is some airlines are buying more sophisticated medical equipment in terms of digital thermometers, digital sphygmomanometers, and even devices capable of transmitting EKGs, where in real time, while you are collecting all these data in terms of temperature, oxygen saturation, EKG, blood pressure, etc., they would be transmitted in real time to the ground-based medical support. But this is not widely available, and it depends on the airline and on the type of aircraft. Now, one notable thing as I was doing my literature review is that there is significant variation in the available resources across airlines worldwide. You cannot really expect to find the exact same resources on two different aircrafts, when you're traveling. However, in the U.S., the FAA, the Federal Aviation Administration, requires passenger-carrying aircraft with maximum payload capacity of over 7,500 pounds and at least one flight attendant to carry an emergency medical kit with specified contents, in addition to a first aid kit and an AED. So things are more standardized here in the US, thanks to this guidance from the FAA. And here I'm showing some pictures of how a medical kit would look like on an aircraft if you have not seen one. These pictures are taken by a blog from KLM, where they had an article, discussing what resources they have on board and how they look like. So obviously you see a medical kit, which is open here and contains a number of drugs and supplies. And then you have a medication bag, which contains different kinds of medications, which I will go through in a bit, and you do have an AED. So what does FAA mandate to be contained in an emergency medical kit? So let's go through equipment first, and then we'll go through medications. And this table is taken from the JAMA review I was referring to. But and you can read this, but these kits are mandated to have oropharyngeal airways, but not endotracheal tubes. They are mandated to have things like tape, alcohol sponges, a IV start kit, needles, gloves, sphygmomanometer, stethoscope, syringes, scissors, tourniquets for intravenous catheter placement, and ambu bags of 3 different sizes. Now, additional contents you will frequently find, but is not mandated, would be things like cord clamps, including umbilical cord clamps, endotracheal tubes, along with the laryngoscope blade, a glucometer, a thermometer, a tourniquet for hemorrhage, and a urinary catheter. So there can be quite a bit of variation there. Now, in terms of medication, the FAA mandates the medications here on the left-hand side of this table, usually an analgesic, a non-narcotic analgesic, traditionally acetaminophen, an injectable antihistamine, but also oral antihistamine, high-dose aspirin, so 325 milligrams, atropine, an inhaled bronchodilator, D50, epinephrine, both in IV and IM form, lidocaine, nitroglycerin, and 500 cc's of saline. Now, you will frequently find other medications that the airline decides to carry, but that are, again, not mandated. I will highlight a few here. Many airlines carry steroids, either dexamethasone here or methylprednisolone. You will frequently find benzodiazepines, specifically diazepam, or lorazepam. These would be important in situations of anxiety, but even more important in the setting of seizures, if you're trying to treat an incident seizure. Some cardiac medications such as digoxin, furosemide, metoprolol, right here, epinephrine autoinjectors, glucagon, ibuprofen as an additional medication to treat pain. Sometimes you would have morphine, and then naloxone, and some medications to treat GI symptoms such as ondansetron and promethazine. So again, a lot of variability, but this nicely shows what is mandated and what is optional, and gives you an idea what could be available on an aircraft. Now, the question is, what is commonly being used on an aircraft and in the setting of an in-flight medical emergency? And going back to the study by Peterson et al., the most common therapy was the use of supplemental oxygen at 50%. So it was by far the most commonly used therapy. But after that, normal saline and aspirin at about 5% each, nitroglycerin, an over-the-counter analgesic, and an anti-emetic at 2 to 3% each. Albuterol was about 1%, and no medications was needed to be used in about 40% of these events. I want to talk briefly about AEDs. So there was a study that looked at how they were used, and 24% of the time they were used for an actual cardiac arrest, and 76% of the time they were used for cardiac monitoring. The initial rhythm during a cardiac arrest were asystole 40%, PEA 35%, and VFib or pulseless VTach at 25%. One thing I found really, really interesting is that cardiac arrests inside the airports, the initial rhythm was VFib or pulseless VTach in 87% of cases. Compare this to only 25% of cases while in flight. And this is hypothesized to be due to late recognition, right? I mean, especially on long distance flights, people may be assumed to be sleeping, you know, but in fact would later be discovered to be unconscious and in cardiac arrest. For cardiac monitoring, the most common rhythm was sinus, but AFib, A-flutter was present in 5%, complete heart block in 3%, and supraventricular tachycardia in 3%. And one thing I came across when I was reading the literature is if you are in a cardiac arrest situation and you're needing to use the AED for defibrillation, keep the pads on even after ROSC. I mean, keep them on as long as you can, because there have been some case reports where some people required as many as 20 shocks. So you do not want to remove these pads early or discard them early, especially with the limited resources you have on board. I mean, you will not have many sets of pads to use, so keep that in mind. Real quickly, again, referring to that JAMA review, they have these nice cards of, what to do when you encounter specific events, on an aircraft. And here I'm showing the cards for syncope and near syncope and another card for cardiovascular symptoms. They have 12 different cards in this specific article, which I found very neat just because they kind of guide you through what could be happening and what you could do and what could be available on board. Now, obviously, this makes sense, but obviously in the setting of being tired as a passenger trying to help, having a reference to go to is really nice, especially if you're encountering a situation that falls outside of your medical specialty. So if you're interested, I really recommend that you look at all these 12 cards they have in that article, which were really excellent. So what are the outcomes of IFMEs? So first of all, you will get the question, like, do you recommend that the aircraft be diverted? Either you as a provider on flight or the ground-based medical providers recommend that the flight be diverted, that's fine, but it's only advice to the captain. Okay, you do not have the final word on whether the aircraft is diverted or not. It is the captain who always decides whether the aircraft is diverted, because the captain has to factor many other factors that can affect overall, the safety of all passengers and of the aircraft. And these include weather conditions, the fuel load, and the need to drop fuel prior to landing, air traffic control, and whether it makes sense, like, to divert the aircraft because the closest airport may not have a runway long enough for that specific aircraft to land, or the medical facilities close to that airport may not have the resources necessary to address the specific situations, let's say an ICU bed or certain resources or equipment. So something to keep in mind. Now, about 7% of events required aircraft diversions in the study by Peterson. And cardiac arrest, like most of them, 58% of them did lead to a cardiac diversion, to an aircraft diversion, which obviously makes sense, because at this point you would really need ICU capacity. Cardiac symptoms such as chest pain, 18% of these events led to cardiac diversions. Again, important, especially if you need revascularization. OBGYN symptoms at 18%, possible stroke at 16%, again, important for timely administration of TPA, and seizures at 12%. Now, just a quick interesting note is that in cases of nausea or vomiting, whether a passenger received an anti-emetic did affect the rate of diversion of the aircraft. So if the passenger did receive an anti-emetic, only the flight was diverted only 0.9% of the time. But if the passenger did not receive an anti-emetic, it was diverted 5.4% of the time. So, keep that in mind. However, when looking at other situations and other therapy, no difference in aircraft diversion was found whether albuterol was administered for respiratory symptoms and whether nitroglycerin was administered for cardiac symptoms. Obviously, some reasons for that would be that, if you are dealing with a STEMI, yes, nitroglycerin would be helpful, but you will get to the point where you'll need revascularization and aircraft diversion may be the only solution to be able to do that in a timely manner. In terms of outcomes of IFMEs from that same studies, and you see how they broke it down here, like about 70% of flights had EMS requested to meet them on the ground when they landed. Of these, about a third had EMS actually meet them and transport the patient to the nearest hospital. And of these, about a third were admitted or left against medical advice. So this gives you a general sense of the outcomes of these events. Now, as you can see, there were some deaths. There was a total of 36 deaths, in that study, which roughly equates to 1 death per 20 million passengers. So it's rather an uncommon occurrence, and about 85% of these deaths occurred while in flight. And I want to end this talk by briefly touching on the legal protection for Good Samaritans responding to such emergencies in flights. And So basically, back in 1998, Congress passed the Aviation Medical Assistance Act, and basically it says that the Samaritan is protected against malpractice litigation if he or she is medically qualified to perform the service, acts voluntarily, acts in good faith, doesn't engage in gross negligence, and receive no monetary compensation. So airlines will usually not compensate you for this. Now, you may get a travel voucher, you may get a seat upgrade, which are not usually considered as actual compensation, but you cannot and you should not get more than that. Now, that being said, there have been cases brought against Good Samaritans, and I highlight one of them here by Dr. Noel, published in the New England back in 2002. And I'll basically read what he described. Is that at the conclusion of my first year of surgical residency as a licensed physician, I provided care to a woman during a transatlantic flight. This unfortunate woman had severe asthma and had a mid-flight attack that was fatal. I, along with a physician and a nurse from England and members of the flight crew, performed cardiopulmonary resuscitation for nearly 2 hours. I was later summoned to appear in both federal and state courts because of lawsuits. Only after I recruited the assistant of my surgical department would my residency hospital provide me with legal support. After I had several sessions with a lawyer, reviewed documents, and provided a deposition, I was dismissed from the lawsuits on the basis of Good Samaritan protection. So a couple of things I want to say here. One, you are in the US, you are not mandated by law to serve as a Good Samaritan. However, obviously, it is considered ethical to do so. Number two, to my knowledge, and I reviewed the literature again, there has been no litigation brought against healthcare providers in such situations. But there, as you can see, sometimes there have been situations where healthcare providers were summoned to appear to courts, and so far they have been protected by the Medical Assistance Act. And obviously, this can be stressful on a number of levels. One, because it is a lot of stress, right? I mean, going to court and making your case and providing documents and this and that. But also, it's not always clear-cut how you will get help and who will represent you. Because your hospital may not be able to represent you. Airlines are not usually available to represent you and do not have such guidelines to do so. And finally, your malpractice insurance may not cover such events. So it could be that you could find yourself fighting through this. So, but again, the good news is that there is this act, which is Aviation Medical Assistance Act, and that to date, there has been no litigation brought against healthcare providers in the U.S. Now, really quickly, I will note that international law is different because the laws of any country may apply, including the departure country, the destination country, the airlines country, and I may add to that also your own country and the patient's country, I mean the passenger needing medical help's country. So things are not well delineated in that case. And I'll also say that certain countries like France and Germany will require physicians to help during in-flight medical emergencies because they regulate air travel under civil law. So in certain countries, it is required to help. It's not optional. And again, I'm not aware of suits brought against medical providers in these countries if the provider did not help. But I will tell you, I did encounter a situation where I was in college and we had an in-flight medical emergency, and I was sitting next to a cardiologist, and his wife was prompting him to go help with the emergency, and he didn't want to. I mean, luckily we were about to take off. We were still on the ground. We had to go back, taxi to the gate so that this passenger can get help. But sometimes, medical providers may decide not to help, but it's obviously considered an ethical duty to do so. Very quickly, there are certain tips to avoid legal complications, and this include identifying yourself and your medical qualifications, requesting an interpreter when possible if the passenger does not speak your language, obtain a complete history as possible. And I give an example in the case report of the Bell's palsy in the Annals of Internal Medicine, where that physician did take a very complete history, obtain consent when possible, always inform the flight crew of your clinical impression. If the condition is serious, definitely recommend the aircraft be diverted. Now, the captain will decide what they decide, but if you think the aircraft need to be diverted, this should be your recommendation, obviously. Establish communication with ground-based medical staff, and this is important because these physicians have a lot of experience in such situations, so getting their recommendations and acting on them would be very helpful. Document everything in writing, and I've done that. And sometimes the airline would have a form for you to fill, but sometimes they may not. And it would be a good idea to write everything down on paper, just in case there happens to be some follow-up or some complications, whether medical or legal, related to the case you help treat. And obviously, do not use any treatment that you do not feel confident administering. You are not obliged to try something you have not done before, especially if you're unfamiliar with a certain equipment or a certain medication. So I want to close with going back to our passenger, which is a case scenario I started with. So obviously, as I was starting to evaluate this patient, I had a quick differential go through my mind. You know, is this cardiac arrest? Is this hypoglycemia, seizure, especially status epilepticus, because she was totally unconscious. A vasovagal event, which is the most common cause of such events. PE, especially that she was pregnant, some ingestion or a medication side effect, what was her past medical history, and was this related to her pregnancy? So obviously right away, you deal with your ABCs, and she was unconscious, but she was breathing. I reached out for pulses. So she did have a strong carotid and radial pulse, which was reassuring. So, I suspected a vasovagal event at this point. One thing that I did, and I was helped with that by a physician and another physician and a nurse, is, we raised her legs and we positioned her on the left side specifically to decrease IVC compression in the setting of her advanced pregnancy. She was in her eighth months of pregnancy, which did help. She eventually, woke up and started talking to us, which was very reassuring and a huge relief for all of us. I tried to measure her blood pressure. I mean, obviously, it is very, very hard because there's tons of noise on the aircraft. To the best I can tell, her blood pressure was 110/60, but this was an estimate. I tried to get an O2 set, but the pulse oximeter was not working. I tried to get a blood glucose, but it was really unclear how to operate the glucometer, even after talking to the other physician and the cabin crew. And finally, I was able to get more of a history. So she was in her 8th month of pregnancy. She did not have a past medical history. She was on no chronic medications. She had no complications related to her pregnancy. We eventually were able to land without needing to divert the aircraft. And upon landing, I recommended that she seeks medical assistance because she had another flight all the way to Montreal, which was an 8-hour flight, but she was not sure she wanted to do so. But at that point, she had help from ground-based medical support at the airport, and I had to leave to catch my other flight, but she seemed okay. So anyway, thanks for listening, and I'm happy to take any questions.